Good morning, everyone. Welcome to today's discussion on race, racism, and disease. Alan and I are so thrilled to have the incredible group of speakers we have today. I just wanted to take a moment before we introduce this wonderful group just to speak a little bit about the importance of today's session. I think as Alan and I conceptualized this course, it became very clear to us early on that we needed to address this moment really through the lens of race and racism in our country, because it's really essential to understand this moment in that context and also what this moment is teaching us about our own humanity. As many of us have discussed, in many ways, there is an analogy to the HIV pandemic when it exposed the underlying challenges that the LGBTQ community faced in our country. And in similar ways, COVID is really exposing the centuries of wounds that have been inflicted on people of color in this country, and now has provided, in a way, a singular lens for us to focus on race and racism and addressing these issues. And so it's in that context that we're having today's session, but also an awareness that we have attempted and will continue to attempt to thread this throughout the course, that this is an ongoing discussion and that we welcome the exchanges that we've had with you all and appreciate this dialogue and feel so fortunate to have these four speakers who are joining us today, who have dedicated much of their entire life's work to addressing these fundamental issues. And we're so grateful for their presence. So I'm going to hand this over to Alan to introduce our speakers.
Thanks, Ingrid. I just would underscore what Ingrid has said. I've had a sense that we've talked about a lot in the course that epidemics, pandemics reveal the most basic and serious fault lines of a society. The language has now become familiar to you. Epidemics lay bare every aspect of our culture, our society, and especially inequalities. And that's been true from the beginning of the COVID pandemic. I sometimes have had a sense over these recent weeks, it's like somebody turns on a light in a room that is completely dark. And there are things that have been invisible to us, even though they crucially affect everyone every day. And then the light goes on and it's hard to see. But for at least a brief time, you have the possibility of opening up the most serious questions that confront a society and politics around issues of justice, equality, and especially injustice. And that's been profoundly true of COVID-19. And when Ingrid and I were planning, there are many excellent experts in this area who have actually devoted their careers to studying these problems. But their work has incredibly powerful resonance in the context of the pandemic. And we were able to get some of the people who honestly we admire most in the world to participate in the course today. So I will briefly introduce them. We want to leave a lot of time, or as much as we possibly can, for you to make comments or ask questions. The first speaker will be my colleague in the Department of the History of Science and my boss. She's chair of the Department of the History of Science. She also is a professor in the Department of African and African-American Studies here at Harvard, a former dean of Harvard College. And I would just say about Professor Hammonds' work, she has throughout her career illuminated strategies for how to think historically and in contemporary ways about the category and the concept of race. And I invite all of you to explore her work on gender, race, sexuality, and I think it has particular immediate relevance for how we understand COVID-19. So it's great to have Professor Hammonds here. Our second speaker will be Dr. Margarita Alegria. And Dr. Alegria is a leading expert on health disparities. She's the chief of the Disparities Research Unit at the Mass General Hospital. And she has devoted her career especially to understanding how to correct and reduce and fundamentally end health disparities that are based on race, ethnicity, and culture. Her work is especially notable for bringing strategies for community involvement in improving health services to people who have had difficulty of access and are fundamentally underserved. The third speaker will be Dr. Sonya Shin. She's a colleague of mine in the Department of Global Health and Social Medicine at Harvard Medical School, and she's active in the Division of Global Health, what is the term? Global Health Equity at the Brigham and Women's Hospital. But what's so impressive about Dr. Shin is that she has spent the last decade working in the Navajo Nation, building collaborations and with tribal leaders and the health teams there to help develop new strategies, especially with community health workers, for improving the health of a greatly underserved community. And I couldn't help but think as we were preparing for today's session, the combination of expropriation of labor through slavery and the expropriation of land are at the very center of any understanding of American history. And so we see those issues in our speakers' work in a fundamental way today. The last speaker will be Dr. Camara Phyllis Jones. I very fortunately got to know Dr. Jones very well over the last academic year. We were fellows together at Radcliffe's Institute for Advanced Study, which not that many undergraduates have contact with, but it's really one of Harvard's remarkable units, and it brings together people from all disciplines. And I have to say, Dr. Jones's curiosity and intensity of learning, not to mention her remarkable expertise in developing new and testable and effective strategies for anti-racism, was really at the center of our discussions at Radcliffe. And I invite all of you to take a look at her work. She's a former president of the American Public Health Association. She's a family physician and an epidemiologist who, I say with some gratification, trained at our School of Public Health here. She's associated with Morehouse School of Medicine and Emory's School of Public Health. And it's really fantastic to be able to welcome her here today as well. So now I will turn to Professor Hammonds, and I want to thank all of you for being here today.
Thank you, Alan. It's really wonderful to be a part of this course. It's just absolutely fantastic. And I'm happy to be here to just share a few of my own thoughts and insights about what's going on as we are living through this pandemic. So first thing I want to do is share my screen. So of course, we're talking about confronting COVID, science, history, and policy. The first thing I just wanted to reiterate what Alan said, opening up today's class. From my perspective, also as a historian of science and medicine, it's very clear that pandemics don't produce inequalities, that they reveal them. And there are two crises that have defined the summer and late spring of 2020, and that was the escalating police violence and the worsening pandemic of COVID-19, and both have disproportionately targeted communities of color. And so while I think the killing or maiming of people of color by state authorities is far more visible in certain respects, the extraneous failures in healthcare and public health are actually much more numerous. And I think that the privatization of healthcare and the failed policy decisions by the government have really led to persistent, stark racial disparities in health that we are very aware of. And I think the pandemic has revealed and exacerbated some of those disparities. So just to say some of the data, and I think other folks will be commenting on this as well, Black and Latino Americans are roughly 2 to 3 times more likely than their white counterparts to contract the coronavirus, roughly 4 times more likely to be hospitalized by it, nearly 3 times as likely to die from it. And of course, I think Maggie's going to talk about more about what has been happening in the Latino and Latinx community. And I think that it's important to note at the outset that doctors and scientists who track these case counts and death tolls are pretty horrified by this disparity. And many worry that the true gap is probably even greater than the data indicates. And we are facing some numbers of death and illness at numbers that that we have not seen for a long time. And when I think about what's been happening in African-American communities and the kinds of explanations that people have been offering for the disproportionate impact of COVID, and it's been described by a number of factors. The first one, high rates of existing chronic diseases, diabetes, hypertension, asthma, and obesity are among them. Greater likelihood of African-Americans being uninsured and thus having less access to health care. More exposure to the virus due to holding more low-wage jobs in food services and public transit and hospitals and other public-facing jobs. Decades of discrimination and distrust leading to avoidance of the white-dominated healthcare system. In the beginning of the pandemic, there were rumors on social media that Black people were less susceptible to the virus. And there were also rumors that Black people were more susceptible to the virus due to what some people perceived as biological differences between the races, and I'll come back to that point. Other people have pointed to structural inequalities in health, wealth, housing, and education. And I would have to say about all these points that there are elements of each of them that I have observed in discussions and reports of every outbreak of epidemic disease in US cities that I've studied since the 18th century to the present. But the thing I want to call your attention to think about these issues historically is really centered on this chart. And if you look at the first chart A, it's the age-adjusted mortality on a logarithmic scale, and it goes from 1900 to 2020. And as you can see, the light blue reflects African-American age-adjusted mortality, and the darker line shows the white mortality rate. And you can see from 1900 to 2020, there has never been a time when Black mortality has been less than white mortality rates. That is a significant and important backdrop and background for me, particularly as a historian, to understand and begin to ask questions about, and the basic most important question here is why? Why has this kind of difference and disparity in mortality rates existed for well over a century? And actually, it's probably earlier. We don't have the data. Some of the data prior to 1900 is not as robust, but we do know that there was disparities in that moment as well. And then life expectancy is on the other chart, and you can see as well the ways in which Black mortality, life expectancy has been lower than white, again, from 1900 to 2020. And the roots of all these disparities are, and that's my dog, and I will see if I can, if he will not try to participate in this conversation. But the roots of these disparities are difficult and deep, and they're hard to disentangle. It might be that the presence of greater chronic illness might stem from diet or lack of health insurance, but that doesn't really explain for many of us why Black and certainly Latino Americans are more likely to suffer from issues of food insecurity or to work in low-paying jobs in the first place. So to answer these questions, you have to dig deeper into housing, immigration, education, labor policies that date back to the nation's founding and actually really point to specifically issues of systemic racism. So let me tell you why I think history matters, and I'll raise these points and we could talk about them more as in the discussion. We have to understand, first of all, as historians, what happened at the end of slavery, when almost 1 million African Americans were who had been enslaved were free. How did they survive? What kinds of situations did they face? We have to continue to analyze the failures of the federal government during the period of Reconstruction, right after the Civil War, when this newly enslaved population had very little housing, very little access to jobs, very little ways to provide for themselves in the economic system of the United States at that time. We also historically have to look at how theories of racial difference provided a natural explanation for restricting African Americans' access to jobs, to education, to economic opportunities, and adequate housing, and how those things affected their health status. These are the crucial sets of points that we have to look at historically to understand the two charts that I showed you earlier. We also have to look hard at and demonstrate how public health practices beginning around 1900 that were focused on keeping whites separate from Blacks, who were viewed as sources of contagion for many outbreaks of epidemic diseases that emerged early in the 20th century. And then if you start in 1900, but you can get to 1981, 80 years later, when one historian wrote in a quote that I like to use a lot, that he was trying to understand what he saw as the disparity between white and Blacks and causes of death. And the point that I really want you to look at, and he was saying in the 1980s, it was even then still hard to understand why the differentials had persisted so long up to that point. And he noted, and he thought about it and said that basically what he observed is that in North Carolina, when he was writing about this, and every other Southern state, he found that African Americans lived outside of every legal, medical, and social advance our nation has made in this country. That's 1980. And that tells us something about what had not happened between 1900 and 1981 when he was writing. And so this history then, I have to say, matters a great deal. And in the end, the need to address the systemic racism that the history points to, we know should be a part of the mandate of public health. And having a historical perspective that can tell us where we've been, how we as a nation have failed to incorporate lessons from previous epidemics, makes it difficult for us to understand what is happening and the disproportionate impact on African Americans right now. And I'll just close with a comment that another one of our colleagues wrote over 20 years ago about the importance of history. Because the history tells us, as he noted, the extent to which racism as this sort of fluctuating, shifting in content, but ever-present aspect of American life is still a major public health problem and a challenge to the goals of medicine and science. The failure to address racism is one of the things that the COVID-19 pandemic has revealed. And he noted that it reflects an abandonment of racial justice and equity as national goals. It's not just history. So we can understand the disproportionate impact of COVID on African American communities without going back and doing and answering some of the historical questions that we have not fully answered, and it makes it hard for us to explain persistence of the disproportionate impact of disease on African American communities. Thanks.
Thanks, Evelynn. You've really given us a great sort of historical platform and foundation for understanding so many things that are characteristic of this moment. Let me turn now to Dr. Alegria. So thank you.
If you could start with the slide. Thank you so much for having me. It's an amazing honor to be with this panel. I want to say that you're going to hear a lot of the topics that Evelynn brought. They're going to be repeated because I think, as you will see, there's a basic theme in probably our 4 presentations, and it's a history of dispossession that has really been rampant in communities of color. Let me start. I was asked to talk about the Latinx community, but you'll see how much overlap there is with Evelynn's presentation. Next. I want to start by saying that when COVID hit, there was a lot of, talking about ethnicity or race being the risk factor for disease. But actually, as Tom Sequist said, that's not the risk factor. The risk factor is racism that we see over and over again. This is not new. Actually, people that have done, like Evelynn and others that looked at the history, Spanish flu was the same. There's been a history of all of these epidemics being especially in communities of color. Let me go next. Let me talk about the Latinx, and I'm gonna skip over some of the things that Evelynn mentioned, because we already know that Latinx are more likely to test positive, even though they were tested at the same rate as whites. They're more likely to be hospitalized, 4 times more likely. They are disproportionately burdened by chronic disease. And even if you look, I think the most serious things that I wanted to talk about is age-adjusted COVID-19 death rates for Latino is 2.5 more than whites. Astronomical. This should be race as a tragedy. And there are 53 more times to die than whites. So everywhere you look, you can see that it's really a very serious problem for the Latinx community. Next. I want to show you also how it's not only been the mortality and morbidity, it's been the financial devastation of Latino families. 42% of Latino families said they've gone through all their savings as part of the epidemic. Then you see one of the things that's very unique to the Latino families is a heightened sense of fear, uncertainty, and great threat that has happened because of the anti-immigrant rhetoric that we're suffering. The public charge has made it that people are afraid to even go and quarantine in hotels, for example, in Chelsea, because they're afraid their families are going to be evicted if they find out they're positive. Second, they find out that their families are going to be separated if they find out that they're undocumented. So even in things like quarantine, we couldn't get people to be able to move if they were in a family and were infected to a hotel because of the fear and the associated anxiety and depression that we have seen for both Latinos and Asians, and especially immigrants with small children. Next. Also want to talk, like Evelynn said, and you would see that this is going to repeat many of the things, but 3 areas that are very pertinent to Latino communities. One is the residential and housing insecurity, particularly because Latinos tend to live in very overcrowded family environments, many multi-generational, because of the cost of living in these urban areas. So for example, if you look at California, 18.4% of Latino families live in overcrowded households compared to 2.4% of whites. Look at that disparities, it's huge. Segregation, racial housing segregation linked to asthma and other conditions also puts you at higher risk. And then I want to talk about one of the things that they found very early in the COVID epidemic was what they call the vulnerability index of higher rates of deaths and hospitalizations that CDC created. And it tells that place matters. And those places that have that high vulnerability because unemployment rates, high transient, overcrowding, all of those places are going to have higher rates of deaths. But we're not talking about ethnicity or race. We're talking about the conditions under which we put communities of color. I think the second thing I wanted to emphasize is this residential worker status. Latinx are disproportionately in essential jobs that don't have very good benefits, that have low wages. For example, Latinx workers in essential jobs are 80.6% compared to 76.7% of whites. They have less options to work remotely, dramatically less options to work remotely because of the types of jobs they do. They also are more likely to have, even within the same institutions or stores, to more likely have unstable work schedules. So they can't even plan. Imagine the anxiety that this brings under the conditions of COVID. Lastly, I want to talk about access to health insurance. Latinos are 3 times more likely to be uninsured than whites. 3 times more likely. 41% of the people who were receiving health insurance coverage and lost it because of their jobs, 23% of those were Latinos. And if you're particularly undocumented, you face additional bigger obstacles. And one of the things we saw very early in the COVID epidemic is many people send you to a website, but actually that website was very informative. It just was not in Spanish or other languages. So people were finding that they were being sent to information sources that they were not able to access. So just to put those 3 on the front. Next. I think the other thing that you're seeing is the stress. The stress is particularly serious for Latino communities. According to an APA national poll, they're the highest undergoing stress. Latinos not only represent, like I said, the proportion of those in high proportion in essential jobs. We also see that they're one of the hardest hit by job loss. So imagine, Franquillo did a great meta-analysis of what happens when you have such an effect of a recession or people lose in mass jobs. And the hit is going to be on mental health and substance abuse, because imagine coping with the stress of not being able to actually provide for your family. This combined with the anti-immigrant rhetoric that has affected so many families. And as Evelynn was saying, the Black Lives Matter violence that we are seeing, Black Lives, movement that had to come up because of the struggles of the Black community. All of that confluence of factors really raise, a situation where people find it overwhelming to cope with their everyday lives. Next. I want to show you a very nice work that was done by the Commonwealth Fund, finding who are the respondents who reported experiencing stress, anxiety, or great sadness that found difficult to cope with their own since the COVID-19 pandemic. And you can see here, Blacks and Latinos, again, very high, women very high, and below average income, you can see super high. So again, we see this perpetuating factor that we have done the perfect storm for these populations of color. Let me go to the next slide. I want to call attention to children, because this is one of the areas that I feel it's really, really serious, and we should pay attention because these children, we're putting them in a position that's long lasting. We see increases, as have been reported, in worse mental health outcomes, substance use, and elevated suicidality because all of the problems we're finding in food insecurity, family conflict, and severe poverty that these families are experiencing. We're seeing that children, mostly Latino and African American children, get most of their mental health when they need it through schools. And we're finding that with the school closures, these children do not have an outlet. Same thing for emerging adults. We're having serious, serious issues with emerging adults that can get jobs, that don't know how to, their uncertain future in terms of their academic and career outcomes, and we cannot offer them a lot of help. So this is an area about disruption, food insecurity, lack of resources to attend to children and youth, and the emerging adult population. Next. I also think that we're seeing that with the parents having so much instability and hardship due to COVID, this is going to increase the likelihood that these children have adverse events that can be tied to PTSD and their child development. And I want to emphasize that this is not families are not doing well, they're really resilient. The issue is you cannot undergo cumulative stress day in, day out and not break down because it's just too much. I also want to emphasize that there's a loss of a generation of elders that in our communities of color play a very substantial role for children. So they're really also losing a lot of connections and support by their elders. Next. I want to finish by mentioning a few of the what I think could be policy recommendations, because I think we need to increase the investment. This is a time to invest in social services, especially with the determinants of social determinants of health, to really build up those communities that are in such need of resources. And we know we could identify those communities with all the information we have. We also need to actually expand federal regulations. We have to make them easier so we can provide novel behavioral health treatments that are right now restricted under certain guidelines, but that address the unemployment and the COVID anxiety. I also think we need to have innovative models of care. For example, Celia Falico has talked about the importance of student clinics that really take students out to the communities to see what's happening, open that bubble to see how the struggles of our communities of color. And then I think we need to integrate rather than disaggregate mental health, addiction, and infectious disease under a public health strong model of care that really looks at the whole community rather than specific individuals. And hopefully we can accelerate the training of our workshop. We have a lot of knowledge on our community health workers, our peer advisors, and how we can build community capacity to do the best job possible. Thank you so much, and looking forward to the rest.
Thank you, Dr. Alegria. There's so many crucial points here. We will take them up during the questions. I would just make one observation, which is we tend to think about COVID-19 in a very limited biomedical context among how do you get it, then what can happen to you, how do you avoid it. But the ramifications in communities of the pandemic are profound. And the harms, and of course there are tremendous harms to patients and to the tragic losses of the pandemic, but the concentric circles that your talk represents of the harms of a pandemic and how they're revealed is just one of the most powerful things I think we can learn. The other thing is there's things we can do, and I think that's a crucial element about how we think forward. So now I want to introduce Dr. Shin. It's really great to have you here, and she will give us a perspective that I think is in so many ways consistent, regrettably, with stories from our African-American communities, our Latinx communities, and of course, one of the most profound, underserved, and exploited populations in our history are those of Native peoples.
Thanks, Alan. I hope that you can see my screen.
Yes.
Okay, great,
Yeah.
great. So it's just a phenomenal pleasure to be part of this panel. And so I'm going to try to not do justice to a very broad historical arc in 6 to 8 minutes. So I think when I was reflecting on what we have been through with COVID and trying to sort of like lay this roadmap out to all of you, there are, I think, some very unique aspects of tribal health systems that are probably just worth laying out from the beginning. So some of you might have heard of the Indian Health Services. This is actually a federally run, federally funded healthcare system similar to the VA, the Veterans Administration, but unlike the VA, actually, the tribal healthcare system, Indian Health Service, actually has its origins in treaty rights, which means that it has a very different relationship because we're talking about contractual, legal, and moral obligations of the US federal government to provide comprehensive healthcare to indigenous citizens of the United States. One of the things that actually I think is an asset to the tribal health system is that public health has actually been baked into those treaty rights and to that health system package from the very beginning. So public health nurses have been around since the early 1900s, and paid community health representatives since the 60s. And I think that's actually something that has really been a very important aspect when it came to the time of confronting COVID. And the last thing that I think it's just impossible for me to talk about tribal health systems without discussing this is this notion of self-determination. And I'll come back to this in a different context later, but actually, you know, some of you might be familiar with the fact that in the mid-70s, the federal government put into public law the Self-Determination Act, which allows tribal sovereign governments to actually run their healthcare. So what that means is that they can actually get the federal funding, but rather than have the IHS actually provide the healthcare, they would actually use those fundings to deliver healthcare to their communities. So no matter whether it's a tribally run healthcare system or an IHS system, what we can recognize is that across the board, not surprisingly, IHS is chronically underfunded compared to other healthcare systems. So what this sort of sets as a stage, pre-COVID is, for instance, here on Navajo Nation, is actually, a healthcare system that's got some assets, but is, very understaffed. So in some places, for instance, the vacancy for nurses is like 70% in Navajo Nation. And actually a pretty complex system with both tribally run and federally run facilities that are all trying to kind of interact. So that sets the stage, and then COVID came along, and some of you might be familiar with the media because I think Navajo has been highlighted quite a bit over the past few months. And Navajo Nation was hit hard, and it was hit early. So you can kind of see that we peaked in May, and I think one thing that's actually kind of interesting is that the leadership of Navajo Nation actually took it upon themselves. They knew that this was going to be, highlighted in the media. So they made sure that their own narrative was in there. So President Nez actually was very proactive about not only, sort of speaking publicly and making sure that it was his narrative and not an imposed external narrative, but also enforced very, very aggressive public measures to put into effect quarantine, travel restrictions, et cetera, to the point where now, it has been actually acknowledged as a possible model that other communities could learn from across the United States. So I think one, again, like one important thing is to recognize that Navajo Nation was very proactive about taking on COVID and was very unflinching. But if you think about why were we hit so hard, you know, we've talked already from, you know, some other populations about some of the underlying health risk factors that predispose to greater rates of poor COVID outcomes. And we know that chronic diseases such as diabetes, obesity have been disproportionately represented in Navajo Nation and other American Indian communities. But if you start to ask like sort of the why behind that why, you know, why is that so? Very quickly, we start to confront the structural challenges of inequalities to the, you know, and I actually, sometimes, you know, I forget that this is sort of the context that I live in, where 1 in 3 households might not have access to clean water, and the rates of food insecurity are among the highest reported in any US population. But then, you know, if we want to ask the why behind that why, very quickly it goes to some of the historical US federal policies and commercial interests that have been extremely extractive in terms of diverting water sources. And this map here with the little red dots actually represents the abandoned uranium mines, which have still to this day, you know, largely not been cleaned up and have contributed to challenges in terms of being able to have, you know, exercise true sovereignty and have, you know, food production in a thriving way on Navajo Nation. And in parallel to these sort of land and environmental injustices, there has also been, you know, I would argue, a very systematic policy of the federal government over the past several decades to basically disrupt the cultural continuity of indigenous communities, including forced relocation and the introduction of Western diet in those moments, such as the long walk on Navajo Nation, boarding schools where children were forcibly removed from their families. And now when they've come back to, you know, live in their communities, it's been challenging because they haven't received the teaching, the language, you know, from their elders. And, you know, even to the modern day, I would say that some of these colonial practices are still, you know, experienced. And, you know, it's not just the federal government, but private industry, as you can see from the pervasive strategic marketing of sugar sweetened beverage industries in communities of color. So why does this matter? Well, this is actually one of my favorite groups of researchers that have shown that cultural continuity, the ability to exercise self-determination in terms of like how you control your land, your education, and health systems are protective. You know, these are protective structures that are associated with lower rates of suicide and diabetes in First Nations communities in Canada. So we know that like this ability for Indigenous communities to practice self-governance and to protect their traditions is actually a profoundly important factor. And yet, ironically, you know, those same protective factors have been vulnerabilities, right, in the moment of COVID, where communities are actually, you know, our Navajo patients have a very, very strong network of not just their nuclear family and the multi-generational households, but also the clan system, which connects extended families. And so, you know, most weekends, for instance, you know, grandma would be visited by like, you know, an auntie or a niece or somebody else to just check in. And they're, you know, it's an incredibly mobile community where those connections to each other as relatives are really one of the most important things that defines their social fabric. And that has, you know, those are exactly the lines of transmissions that we've identified in our epilinks in the process of contact tracing. So I kind of just want to take this moment to sort of pause and reflect that when we talk about social determinants of health, you know, social means that these are constructs, these are societally man-made phenomena that can either be detrimental or can be protective. And I want to acknowledge the complexity of both the challenging, you know, and the positive aspects of social determinants of health that we've seen play out in the moment of COVID. And just to close, you know, like personally, I've been doing a lot of work. I'm part of the incident command for contact tracing and happy to talk about that. but I wanted to just give this example of one of the areas where we've been working, with the Navajo Nation as an example of, if COVID is this revelatory moment that has sort of laid bare these long-standing institutional practices of racism and colonialism, it's also, I think, a moment to use COVID as a wedge to drive for equity, and not just to say, okay, we're going to just get by and we're going to deal, but actually to argue, to advance, so that your public health system is actually stronger coming out of COVID, and actually has overcome some of these underlying long-term structures of inequality. And so there's a movement among Indigenous researchers for Indigenous data sovereignty, which really, is founded in this principle of self-determination and this notion that data doesn't belong to an individual, it belongs to a community. And so you can see Navajo Nation actually sits on 3 states. So imagine what it's been like, especially early in the pandemic, for Navajo to have to wrangle just basic data on who's getting COVID in their community when they actually had to get it through 3 state systems. And the states were, varying, but pretty passive around how that information was shared. So early on, the Navajo Epicenter made the determination to actually use a single platform, to track COVID, and are now using that that data, in real time to make their policy decisions. As for instance, gating criteria on how to open up the community. So I just wanted to kind of point to that as an example of exercising self-determination and data sovereignty. And just to close by acknowledging, the ingenuity and the resilience of, many of the partners that I've had the chance to work with, and to acknowledge as well the many, many families who've been affected by COVID. Thanks.
Thanks, Dr. Shin. That's so important. I can't help but be struck, again, from a biomedical or even a traditional public health point of view, we talk about data, but how we collect the data, who has the data, what the data means, has been so crucial to how we understand this pandemic and social inequity in general. And I think that's such a critical point. I want to turn now to Dr. Jones, who has been thinking for a long time in a very concerted and meticulous way, how can we reduce racism? How can we identify it? How can we address it? And how can we be anti-racist? And so it's a real pleasure for me to introduce Dr. Jones.
Thank you. Thank you, Dr. Brandt and Dr. Katz. And I will share my screen. So all this morning, and I know earlier in the course we've been about naming racism, my contribution to this morning's conversation is to equip us with a communication tool for naming racism, because there are 4 key messages that we need to get across in this time and going forward and not falling back. The first is that racism exists. The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that we can act to dismantle racism. So I am going to approach this task with one of my allegories, one of the teaching stories that's based on something that I saw in my own real life. This one I call Dual Reality, a restaurant saga. And the moral of this story is that racism exists. Even if your whole life experience has screamed that this is, the land of equal opportunity. So the story is based on an experience I had as a first-year medical student. So come walk with me. As a first-year medical student, I was very diligent, of course, very studious. And one Saturday I woke up early, and what do? I hit those books, and I hit them hard, studying well into the afternoon. And then some friends come over, and do they distract me? Oh no. So all of us get to studying long and hard, and now it's getting late and we're getting hungry, and I have no food in the apartment, which was quite typical of me. So my friends understood. They said, never mind, Camara, let's go into town and find something to eat. So we do. So we walk into town and we see a restaurant and we walk in and we sit down and the menus are presented and we order our food and the food is served and here we are eating. And so you're like, Dr. Jones, that's not a very illuminating or remarkable story about racism. Oh no, not yet. But as I sat there eating with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now maybe I've intrigued you and you're like, Dr. Jones, what did the sign say? Oh, okay, what did the sign say? The sign said open. So now maybe I've lost some of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room, I see a sign that says open, thinking no more about it. I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now indeed the restaurant was closed due to the hour, but firmly closed, and that other hungry people, just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I recognized that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant, at the table of opportunity, eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it's difficult for any of us to recognize a system of inequity that privileges us. So for example, it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context. But those on the other side of the sign, those on the outside, are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, but if you do, why, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door? Let them come in. You'll make more money. And oh, the conversations we could have. Or maybe what you'll do is pass food through the window. Or maybe you'll try to tear down that sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. So this is the story I tell when I have 4 minutes to convey to a group of people that yes, racism exists. It's creating a two-sided or multi-sided sign in our society. It's structuring a dual or multifaceted reality. And of course, racism is not just the sign, it's the door, it's the lock, it's all of these structures and communicate all of these value assessments. It's all of that. And I actually started a 3-hour conversation once in Flint, Michigan, after just telling this story, 4-minute story, with the question, how could people who are born inside the restaurant know something about the two-sided nature of that sign? And it was a 3-hour conversation because there are many, many ways to know. What I have to say right now is that I'm heartened that more people who've been born inside the restaurant have an inkling in these past few months about the two-sided nature of the sign. First of all, with the COVID-19 pandemic ripping the sheets off of structural racism in our society, and with the very public lynching of Mr. George Floyd and people before and people after, that we are now aware. People who are inside the restaurant understand, maybe the sign flipped for a minute. And I say, this is great. I am heartened that there are more people who, instead of saying, what are those people outside saying? Black lives matter? Don't they know all lives matter? Well, now more people are saying, are affirming that, for example, Black lives matter. More people are putting together the words structural racism, systemic racism. But my warning to all of us is that if we just say a thing, put out a declaration, make a statement on our website or whatever, it's important to say the thing. Naming racism is essential, it's necessary, but it's insufficient. But if we just say a thing, then 6 months from now, we may forget why we said that thing, because the seductiveness of racism denial in this nation is so powerful that 6 months from now, if we just say a thing, we might fall back into what I describe as the somnolence, the sleepiness of racism denial. We must act to tear down the sign, dismantle the lock, take the door off the hinges, because if we start acting, we won't forget why we're acting. So very quickly, I want to just race through my definition of racism. I've said the word a few times. We've been talking about it all morning. When I say the word racism, I'm clear that I'm talking about a system. So I'm not talking about an individual character flaw or personal moral failing or even psychiatric illness, as some people have suggested. And it can manifest in those ways. But in its essence, it's a system of power. A system of power of doing what? System of doing two things: structuring opportunity and assigning value. On what basis? On the basis of what we call race, which is the social interpretation of how one looks in our race-conscious society. What are the impacts of this system? Well, when we think of racism at all, we recognize that racism unfairly disadvantages some individuals and communities, but every unfair disadvantage has its reciprocal unfair advantage. So racism is also, also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people who are living as white especially uncomfortable. And I used to apologize. I used to say, if you feel uncomfortable, shake it off. I'll tell you some more stories. I don't say that anymore. I say, if talking about how racism unfairly advantages other individuals and communities makes you uncomfortable, lean in. I encourage you to lean into that discomfort, because for all of us, the edge of our comfort is our growing edge. But there's a third impact of racism, which is that it saps the strength of the whole society through the waste of human resources. And so rounding around to the bend, of course, there's so much more I would love to talk to you about. In fact, I would say that the national campaign against racism that I launched 4 years ago as president of the American Public Health Association had 3 tasks: to name racism, to ask how is racism operating here, and then to organize and strategize to act. So what can we do today? What are kind of the classifications of types of actions we can have? First, going back to the restaurant, we need to actively look for evidence of two-sided signs. Is there something differential going on here by race, by language, by ethnicity, by immigration status, by sexual orientation, by zip code, by urban, rural, by anything, religion, all. And we need to look not only at differences in outcomes, but also differences in opportunity structures. We cannot be reassured that, oh, looks open to me. Oh no. We need to burst through our bubbles of experience to experience our common humanity. Each of us lives in a bubble of experience. Most of us do not recognize that just across town, there are people who are just as kind, funny, generous, hardworking, and smart as we are, who are living in very different circumstances. We need to burst through our bubbles to experience our common humanity in different circumstances and then build common cause. We need to be interested in the stories of others, and then believe the stories of others without requiring cell phone video, and then join in the stories of others. And I'm heartened that many more people are doing that these days. We need to develop a sensitivity to the absence of, because it's through, who's not at the table. We need to understand what is not on the agenda, what policies are not in place that if put in place could be quite productive. And we need to reveal inaction in the face of need, because that is the way that structural racism most often manifests these days. Lack of action, inaction in the face of need. But all of the power and the stuff is not on, only on the inside with the people who are sitting inside the restaurant eating, right? Those of us on the outside need to know our power. We need to recognize that action is power, and especially that collective action is power. So, I wish I could have my usual 2 hours. I know I don't, so I'm going to stop sharing, and I look forward to all of our questions.
Wow, thank you. Thank you all so much. This has been a phenomenal group. And I have to just say, Harvard is so lucky to have you all. I mean, really, we are blessed to have you in our session today, but Harvard is so lucky to have you all. on their faculty. And I know for the students in this class, I've seen a lot of messages in the Q&A about how grateful they are to hear your voices as women of color in this moment, lifting up the voices of so many and addressing these critical issues in our country right now. And I just have to say how deeply grateful Alan and I are to have you here. And really addressing, as Dr. Shin said, the why behind the why. What is the why behind the why? What is our history? What is our humanity? What is our role as researchers, as physicians, as public health advocates, as historians? This is the moment that calls upon all of us. And I think, and I hope for our students here today, you've had a chance to take this in and reflect upon this work as you continue to move forward, as you continue to educate yourselves about all of these issues. Many of you have already had scholarship in this area, and I encourage you to read the work of these 4 great leaders as we now turn to questions. So again, I want to thank you all, and I'm going to pass it on to our students, really, who have quite a few wonderful questions. Thank you.